Hello everyone, welcome back to our episode number 5 for our FRCR training platform, mainly for our candidates who are preparing for exam to see whether it will help them to prepare for the future. So this episode also we are trying to go through a real viva situation for 15 minutes with the candidate. We want to be anonymized, so we can't reveal the candidate name, but they are preparing for exam in few months time. So thank you madam for coming and ready.
Yes.
Okay, so first case, this is patient which I say is not well.
Okay. So the frontal radiograph of the skeletally mature patient shows uh, widespread areas of airspace opacities in both hemithorax, and within those I can see few cystic lucences predominantly in right upper and left upper and middle lobe. Um, taking some time to review to see my review areas. Mm, so yeah, uh, uh, if it is not projection, some form of air trapping in bilateral lung apices and the bases, or I can say the apices and lung bases are spared of these opacities. Um, Apart from a few cosmetic jewelry, piercing, and
What is cosmetic jewelry means?
I can see nipple piercing on
Okay,
both sides.
that's fine.
Yeah, and yeah, so the cardiomediastinal contour appears normal, and bony thorax and soft tissue appears normal, and the visualized upper abdomen appears normal. So to compile my findings, I would say my first differential as
So summarize the findings.
there are bilateral perihilar airspace opacities with cystic lucences within. Um,
What is that arrow there on the other side here?
yeah, so I would say um,
Okay.
yeah, there are bulle formation
Okay.
on
Good.
both
Good.
sides.
Good. Good.
Yeah. So a component of fibrosis and a component of um, emphysema. So my first differential would be presence of both combined emphysema and pulmonary emphysema and fibrosis. My second differential would be infection with um,
So you summarized to say perihilar opacity, then cystic changes. Yeah.
yeah.
And
So
as what I said in the beginning, patient was
unwell.
unwell.
In my routine practice, I would like to discuss this with my referring physician and go for a cross-sectional imaging to get more insight into patients.
But there are airspace perihilar opacities, or even on the CT scan, there are few areas of emphysematous bullae, widespread upper zone, and what you said, the pleural CP angle where
Was spared. So
spared.
this would come into the definitions of upper zone fibrosis with tuberculosis, silicosis, and
Okay.
um, berylliosis as my differentials.
What do you think is common?
Tuberculosis.
Okay. Why you get tuberculosis and due to
Mycobacterium tubercular infection.
patient? Do everybody gets TB or
No, the patients with a lower immune
okay?
status.
What else the patient with lower immune status can get?
Yeah, so I can raise the possibility of immunodeficiency virus infection,
Okay. What they're called?
HIV,
What
AIDS,
infection they call in chest?
pneumocystis canine pneumonia.
Okay. So how you treat them? What you do next? Okay, you done a CT, you saw the same finding, no extra findings, and you see how you treat them, how you manage this patient.
Patient is put into antivirals, retroviral therapy.
These bacteria or this infection is
This is the
bacteria?
parasitic infection.
Are they prognosis wise? Do you
So
think
the
these are the
patient CD4 count is monitored,
okay?
and there are like if it drops below 200, the patient is susceptible for MAC infections.
Okay, okay, we'll move on. So this is a radiograph, a patient with chronic foot pain.
Okay, so I'm giving
I know the projection is not clear, but there's single projection. Yeah.
so I have been provided with single projection of foot, frontal projection of foot. Um, taking time to review through the entire X-ray. Okay. So I can see there is an increased amount of sclerosis density in the midfoot region. I cannot very well delineate the subtalar joints, the ankle joint, and uh, along the proximal parts of metatarsals there is the thickening of the bones, and there's component of deformity and disorganization. The soft tissues are not very well clear in between the joints. However, distally, if I see the phalanges and there's no component of acrosteolysis, and the interphalangeal joint space and metatarsophalangeal joint space is preserved, but I cannot make out the joint space here in the ankle and talar subtalar region. Um, and there is some component of cortical breach in the medial aspect of the foot bones. So to combine all the features, my top differential would be of a neuropathic joint, charcot joint arthropathy.
Charcot joint. Okay. What is the typical features of Charcot joint?
So there are two types. It could be atrophic and hypertrophic form. So in the hypertrophic form, you see the most common 5Ds.
Okay.
Yeah,
You know what other D's, yeah?
yeah. The
Okay.
density,
So what is
disorganization,
the most common cause of Charcots nowadays?
diabetes.
Diabetes. Is there any evidence here?
I'm trying to look for vessel wall calcification.
You don't see it.
I don't know.
Okay.
And,
So if there is ulceration in this and you worrying of infection, what you do?
in this ulceration,
Yeah, also in the foot.
so it could be osteomyelitis. I
So
need to.
how you investigate?
So I would like to see Charcot patients are usually painless, and while osteomyelitis and other patient would have a pain
Yeah,
and
yeah.
swollen.
So what you do next?
So I'd like to have a cross-sectional image of the patient and also the biochemical
What is
work.
cross sectional? What cross section?
MR of the foot
What sequence you'll do?
stir to look for marrow edema and exclude osteomyelitis.
Do you give contrast?
Mm. Contrast for Charcot, I'm not sure, but for osteomyelitis, I'm sure to rule out to delineate the sinus tract.
So move on. This is one more. Next patient. Just
So, um, frontal radiograph of abdominal pelvis or say KUB region. Coming to the line, I can see an external line with
mm,
extension into pelvis. I'm not sure whether it's intraperitoneal or extraperitoneal.
where is coming from?
It's coming from, say, from the right hypochondrial region.
How big is the tube?
It's quite big.
Okay.
Mm,
Wide. Okay.
yeah, but not sure. So then I can see air lucences in the overlying the liver shadows in between the in the 11th intercostal space on the right side. Gastric lumen. You can see the gastric shadow. The large bowel appears fecal loaded. Like some component of spina bifida in L5 vertebra. Yeah, so I see a drain, an
Mm.
external tube, I see air lucences in the region of liver, um, and a spinal
So
bifida.
that lucency is extra. It's not in the normal space.
Yeah,
It's not in the bowel.
it could be in the Morrison's hepatorenal
Okay,
pouch.
so there is some lucency air.
Yeah.
Okay. This patient tube is for long time. Patient is chronically unwell.
Is some sort of ambulatory dialysis catheter.
Okay, good.
Um,
Can be possible. So you can explain the air from there. Yeah.
yeah.
So that is there. What do you think about the skeletal?
Yeah, there's increased density in the dorsal vertebra,
Yeah.
especially D12. And
Or all the what? All the bones are a bit looking back.
retrospectively, I see then there's increased density and generalized sclerosis of the bones.
So now
So,
you try to join this all these
yeah,
things. So
to compile the findings, then my top differentials would be of hyperparathyroidism due to
hyperparathyroidism. Due to yeah.
renal failure when if the page this
What are they called? What is called the term?
rubber jersey spine or
Regurgitative spine or renal. There's something.
osteodystrophy.
Is that makes. That's what they are called, is it?
Yeah.
Uh, regurgitative spine is a appearance
Spine
of the board
back and
of the
forth.
yeah, isn't it? Yeah.
Yeah.
So you think all can be joined together, the line and all. Yeah.
Yeah.
Okay. So we had a appearance of this also to help. Is it the same
Yes.
diagnosis?
Yeah. So lateral
Yeah,
rubber
it's not of the
jersey.
same patient, but I'll start to trying to. Okay, we'll stop there. It's about 14 minutes. The viva is finished, and thank you very much for contributing to this viva. You really again did well from point of view that you have no prior knowledge, and you did well. How you think you did? Okay.
Yeah.
Yeah. So I think you this one Ruggerges is fine. Picture frame vertebra Ruggerges is fine. The good thing you were trying to work out what the tube is in a young patient, which is with widened within the pelvic cavity. Most likely either there is a previous surgery, which can be a drain, or it could be a peritoneal catheter in a dialytic catheter. Because when you use a catheter, you are going to insert some air because of the usage, yeah, iotogenic air. That's why you're getting some air outside the lumen of the bowel. The bowel is okay. Bones are sclerotic. In exam, try to join all the findings. So you were able to join this with this and is renal osteodystrophy, Ruggerges spine. Very good. Did very well. This is, I think you worked out. You described well all the D's, destruction, dislocation, deformity, density, all these D's of Charcot foot. This could be either a ossicle of the navicular or it could be even from the destructive bone like skin ulceration. I was asking contrast because normally we don't give contrast routinely. It depends on where you practice because it takes cost and is a lot of side effects of contrast. The stir is a good imaging modality to T1 and stir is very good basic imaging to work out the infection, which is very commonly diabetic foot are so common that you get so many requests you can't give contrast in all, unless you really want to see some abscess cavities, or you can still look on the stir image. Yeah, so that was good. And this one, I think this is a typical exam case. Everybody should know that if there is a nipple shadowing with perihilar opacities and cystic changes, this is PCP. This should, once you see once, you remember next time. You get this only in exams. Not normal practice, you'll not get it. If you get an exam, I'm lucky, I got PCP. The patient was not given history. The examiner asked his patient is acutely unwell, they are very unwell, and you know what it caused PCP and how to treat them. I think you did very well. You'll pass, and I think you gave a good idea for people who are learning also how to approach, and in a difficult situation you're trying to manage the findings and combining together, and this is what in exam will happen. So this was really a real exam experience, and I think you did very well. It's like a course. Yeah, so thank you very much, guys. I hope you got the information. and knowledge about how to approach different types of patients, given the help, the history, and how to bring the findings together. And main thing is to exam is to bring everything, all the findings you say, summarize to one thing, keep it logical, ask some relevant questions, and come to a diagnosis, know some management. And I think you're done well in this one. If you can get, I hope you learn from this, practice on this for your future preparation, have your differential ready. And this is why we're trying to give some advice and ideas to you guys. Thank you, and we'll wait for the next episode. Okay, subscribe to the channel and click the bell icon for getting more information, more learning videos. Okay, thank you,
Thank you.
candidate.